Hi, and welcome back to the MD, PhD, ETC lecture series on the Introduction to Psychiatry. Specifically, we're going to cover bipolar disorder and other mood disorders such as cyclothymia today. I'm your host, Dr. Robert McClay, and this does play off of an earlier talk that I gave about depression. So if you did listen to that lecture, you'll know that one of the things that I talk about in that lecture series is the concept of DSM diagnoses and why there are these checklists. Why you can look at something like DSM and go in there and say, okay, this symptom is here or not, and you have to have a certain number of them to define any of the diagnoses that psychiatrists use in DSM. There are no lab tests or anything for our diagnoses. They're done by description, and that DSM has been a tremendous advance in that it allowed us to be much more reliable, to be able to say that your depression looks like this other person's depression, and therefore what helped the other person might also help you. That makes our diagnoses much more reliable as a whole. And for depression, this has been hugely successful, that you can say, okay, you've got to have 5 out of 9 of these particular symptoms, and it's got to include the cardinal symptoms, etc. It's got to be there consistently for 2 weeks. That's all fairly easy to do. The difficulty comes when we get into bipolar disorder. Bipolar disorder is one of the hardest diagnoses to make in all of psychiatry, and it really does take some experience because the checklists can be horrendously unreliable in this regard. This both contributed to some of the explosions of overdiagnosis, which, if psychiatry is guilty of what we're sometimes accused of over-medicating people and overdiagnosing bipolar disorder, is probably the area that we are most guilty of that, ADHD being possibly a close second, because people would just go down these checklists and goes, yes, I have that. I have too much energy. I'm impulsive. I don't sleep, and self-diagnose this way. And sometimes doctors would diagnose them that way, and definitely drug companies that were looking to sell their medications for bipolar disorder would use it that way. And I would have people come into my office and say, oh, I have this problem with bipolar disorder. I'm manic. When's the last time you had a manic episode? I have a manic episode right now. And I would look at them and I go, no, you are clearly not manic, because this is one of those things that is very distinct if you have seen it a few times. And that a psychiatrist should be able to recognize someone who is in an active manic stage across the room and be able to diagnose that. And really the only way to accurately diagnose bipolar disorder is to see a manic episode. That is the defining feature of bipolar disorder. It's ups and downs, two poles, right? Now, why can we define it with just a manic episode when the depression is actually more common in there? And well, it's down to the rules of what goes up must come down. There are few absolutes in psychiatry, probably none, and this is probably not a 100% rule either, but it's as close as you're ever going to get, is that if you see someone who is manic, you can be pretty dang sure that they're going to have a depressive phase that follows. A quick word, by the way, on the concept of manic depression. Some people think that manic depression just means sort of severe depression, crazy depression, or something like that. No, mania is the opposite of depression. It's looking like you're high, basically, without being on drugs, which is another reason, by the way, that this diagnosis of bipolar disorder is so hard to make, because depending on the level, amphetamine intoxication can essentially be indistinguishable from a manic episode. Someone who's high on amphetamines and mania look very, very similar. Now, psychiatrists are sometimes a little egotistical, and we think that we can tell the difference. Amphetamine intoxication often comes with more irritability, more visual hallucinations than auditory, things like that. But they're very, very difficult to tell apart. So, but if you have seen it, then you start to say, okay, someone who looks like they're on amphetamines and is acting like they're on amphetamines, because biochemically they may be very similar. That individuals have way too much energy. They're not sleeping. They're doing impulsive, reckless things that otherwise they might not do, particularly pleasure-seeking activities. So spending a lot of money, engaging in sexual activity with someone with whom it's probably unwise to do so. And these are defining characteristics of bipolar disorder. But the other thing, and the reason that checklists can be so confusing, is that they have to be consistent. And, we can all get sort of naturally high for short periods of time. And particular diagnoses, such as borderline personality disorder, can look a lot like bipolar disorder for short periods of time. And people will check off all those boxes. But the thing about bipolar disorder is that, again, it's almost like your brain is naturally producing an amphetamine, is that you can just do this for longer than would otherwise be physiologically possible. Probably all questions are bad on this, but if you were to ask someone for, in retrospect, one of the most reliable questions is, what's the longest you can go without sleep and still not feel tired? And most of us will simply burn out by about 36 hours, maybe 72 at the most. I know this from experience. In the days of wooden ships and iron interns, you had to stay up for that long all the time, but we were a mess at that point. But people with bipolar disorder can just feel constantly energized. So there are all these checklist questions which do accurately describe the condition, but in asking in retrospect, people will get the information wrong. And part of that, again, is it's just hard to judge yourself. And there does seem to be something about the nature of memory that makes it very hard to recollect a particular mood state when you're in a different mood state. So people, while they're in these up phases, you can see someone who's just super high. And again, we say that depression usually follows or precedes even more often. People have about 3 times as many depressive episodes per manic episode in most cases. But if you ask them while they're up, have you ever been depressed, they'll often just absolutely deny this. Then you look at their record and discover, oh, you had 6 suicide attempts. So probably you were depressed at one point. And vice versa, when people who you clearly observed being manic, they were running naked through the streets. That's not an exaggeration. I've actually seen people who've done that, and they'll come back and just sort of justify all this and say, oh no, that was just a prank, it was a one-time thing, it was Mardi Gras, it was whatever. And they'll justify that behavior or not remember it at all, just deny that this happened. And it's not that people are probably trying to lie to you or even to try to cover it up so they don't get medicated. Again, there's something about memory that makes it very hard to recollect different mind states. So it can be a very difficult diagnosis to make, but I do encourage you to just watch some other videos of this. There are 2 that I think famous people who sort of almost perfectly emulate this. Now, the problem is, again, as a psychiatrist, I can't diagnose this at a distance, and you're not supposed to for very obvious reasons. But the videos of Robin Williams are often described as what mania looks like, or at least hypomania. There's both, and this is another division that exists. Full-blown mania implies that you're impaired. There's a technical definition in terms of how long it goes on and how many symptoms you have. But really the issue is in mania, you are impaired. And by definition, any of these episodes that would land you in a hospital meets criteria for mania, because you were obviously impaired in that circumstance because it landed you in a hospital. But at the light version, you can often be super productive, super energetic. Something like this Robin Williams clip here, sort of acting as a genie.
Come on, kid. See? Gotta get the snake, see? He's waiting for you. The horror. Young boy up against a giant snake. Jafar, you are nothing but a messenger boy. Beat it, beat it, beat it. Just beat it. Crick 'em, rack 'em, rock 'em, rake. Stick that sword into that snake. You stay out of this. Time for Jafar, cheer. Give me a B, give me a B, give me a P, 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 give me a P, 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 P. What's that spell? Push him back, Jafather, Jafather. Push him back, Jafather. Look at this incredible performance. Al still staying in there with the snake. What do you think, Bill?
That's an example of at least hypomania. Now, it may not be actually bipolar disorder in his case. Robin Williams supposedly used a lot of cocaine, and people can maintain this for short periods of time, just that they run high energy, or it could be cyclothymic, which we'll get into in a minute. But if you see that going on and on and on and on and on, that is at least mania. And sometimes it's not as energized. Again, another famous example where everyone was sort of mentally calculating lithium doses as the video went on was the Sheen video about tiger blood.
I'm by winning. I win here and I win there. Now what? If I'm bipolar, aren't there moments where a guy like crashes and like in the corner, like, oh my God, it's all my mom's fault? Shut up. Shut up. Stop. Move forward.
Have you had any celebrities reach out to you to try and help you?
Yeah, like radical people like Sean Penn and Mel Gibson and Colin Farrell and just radical people, and they're not telling me what to do.
Who gave you the best piece of advice?
Well, they didn't give me any advice, and within that, there's great advice. It was just love, and so just to see. It's oftentimes says unknown, but occasionally a giant marquee name comes through on your caller ID, and it's like winning.
Again, I don't know if Mr. Sheen is in fact abusing drugs in this, or in fact has bipolar disorder, or is just a very good actor. But that this is what it actually looks like. So if you see mania, you're going to see depression, and that defines bipolar disorder. But there are two varieties. There's the variety in which you are impaired in the ups and impaired in the downs. That is classic bipolar disorder, or what's called bipolar disorder type 1. There is a version in which you're running pretty functional at these elevated levels, what we call hypomania, and that's bipolar type 2. That implies that the depression is more of the problem. And why that matters is which direction do we want to treat. Now, a lot of the medications are mood stabilizers. Lithium classically is the textbook one, the predecessor to them all, and they hold both a ceiling to stop mania and a floor to stop people from getting too depressed. But there are some, lamotrigine, for example, that are much better at lifting up the floor, but not so great at controlling the mania. And ones like some of the neuroleptic antipsychotics, say, like olanzapine or Zyprexa, which are good at holding down mania, but not so great at helping the depression, which is why they created a combination medication of fluoxetine Prozac and Zyprexa olanzapine, so that would both lift up using the antidepressant and hold the top. So sometimes you'll see those medications. Now, there is a variety of this, by the way, that is really interesting, because in almost every aspect of DSM, severe impairment is present, but there is a version of this in which both the ups and the downs are not so dramatic, and that's cyclothymia. So in this case, there's hypomanic episodes, but you never full-blown mania, and also never full criteria for major depression. You get in sort of a low-level chronic depressive disorder, and this cycling goes on for years. There is presumably some degree of impairment with this as well. By definition, you've got to be persistent for at least 2 years to meet criteria for this. So at some point in there, it was probably impairing. But it's more of a description when you have someone who looks a lot like bipolar, and it does in fact seem to be biochemical, but it isn't. There is not anywhere near as much research in terms of how to treat this as there is with treating full-blown bipolar disorder, often because it's not as needed. So whereas bipolar disorder, full-blown bipolar disorder, can be incredibly impairing. It also can be one where, again, there are a lot of famous, successful people who have had bipolar disorder, everyone from Handel to Cayenne West, who, if this is controlled, do very, very well. There are many people personally who had sort of one initial severe break, but they got on their medications and they've been stable for decades. And unlike, say, schizophrenia, where we can only make it sort of partially better, with bipolar disorder, we can often make it all the way better. And people can live very normal lives as long as they take their meds. But it is pretty invariably a recurring condition. So don't let it fool you if someone can go even a couple of years without an episode. I have seen that on a couple of occasions. One of my mentors, someone had been diagnosed with bipolar disorder. Not my mentor was not diagnosed. The individual who my mentor saw was diagnosed with bipolar disorder in a hospital, which is the most definitive way to do this, to objectively see the episode. But that person ended up coming into our office and gave a history where like this was just wrong. And again, we psychiatrists see overdiagnosis all the time. So she wrote this long letter saying that basically he had been misdiagnosed. He doesn't really have bipolar disorder. And he didn't need to be on all these meds or in this monitoring program. And then sure enough, a couple years later, this individual was back in my office and was just classically manic again. No mistaking it whatsoever. The stuff comes back. And I'm not knocking her again. Somebody who's a great psychiatrist. It's just, again, really easy to miss. It's really easy to get a wrong history on, but it does cycle and come back if you don't maintain your medication. Sometimes even when you do, people can't get breakthrough symptoms. And there is a concept that's a little controversial of what's called kindling, which basically means that this builds up, that the more uncontrolled episodes they are, the worse they tend to get, that the condition can get worse and worse and worse over time. It might be an observation bias that maybe the ones that were easy to control and we got to control at the beginning never get bad because that was the way they were going to be. But you definitely do see that if people who have recurrent episodes, many over the years, that often someone who started off with relatively mild ones end up with very severe episodes. So this is why, the old joke is even if you're feeling good, you need to keep taking the little white pill. That this is a condition where if you treat it right, you can do well, but if you do wrong, you can't. And that's not fair, that's not fun. It's like diabetes that way, we can't cure it, and it's miserable, but it's controllable. So, and in terms of how you treat that, the old-fashioned mood stabilizers were pretty much lithium was, as I mentioned earlier, is the granddaddy, but you do have to check levels on that. It can be quite toxic if you get it wrong. To some extent, that's also true of valproic acid or carbamazepine, two anti-seizure agents that were old school mood stabilizers, but you do have to check levels and they can be toxic if you get it wrong. Really the game changers in this is the discovery of some of the newer antipsychotics. Olanzapine was the first one to really demonstrate this. Can be very good mood stabilizers, and as they've gotten newer, they've gotten much better at treating the depressive part. So something like Latuda, one of the new meds, has very good antidepressant properties in addition to antipsychotic and anti-manic properties. So there are different ways to control this these days. People can do very, very well, but look out for this condition. Again, if you see someone who looks like one of those earlier videos of Charlie Sheen or Robin Williams, be very suspicious, but observe over time, because people can maybe do that in bursts. Definitely you can have a drug screen that artificially explains this, but if it persists under observed conditions, that is the defining feature. But you also very much have to watch out for the flip side of this, that people go into the same exact depressive episodes as we talked about in major depressive disorder, and because of that, this overall condition can have a very high lethality rate, 10 times the suicide rate of the general population is generally viewed to be sort of the low number in terms of that. The particularly riskiest state that you can run into in terms of suicide, as well as you will sometimes get somebody in what's called a mixed state, which is where you have all the energy and impulsiveness of mania, but also that people feel overtly miserable, sad, and depressed. And that is a very dangerous position to be in. That is something in which if someone is having one, they probably should really be in the hospital, because it's such a high risk of suicide. And that can be compounded by the fact that drugs can mimic this, but again, people are impulsive and pleasure-seeking while they're manic, so often will start off manic and then start using drugs, which makes it dramatically worse. People with bipolar disorder are just much more prone to the effects of stimulants than are individuals without. Even something like coffee can sometimes knock people for a loop. If nothing else, because sleep deprivation is a great way to set off one of these episodes. Now again, back to the stimulant thing, I often say that full-blown mania looks like amphetamines. Hypomania looks like 6 cups of coffee. You need to stay away from those things if you're already in one of these states, because that will definitely bump you up to the next level. The caffeine plus the amphetamine is not a good idea. So to summarize, the checklists are not very good for defining bipolar disorder, but learn to recognize it. If you see mania, you know you've got it for sure. You see depression, you might have it as well. As we covered in the other lecture, you need to ask about that, but asking can be very difficult because people have poor recollections. If you do see it, though, it is a very treatable condition. The medications can be very helpful, and it's very gratifying because you can take someone who is thoroughly psychotic, incapable of functioning in society, and get them back to a pretty much normal life. So, in fact, sometimes it's extraordinary life because they have such energy and creativity associated with this. So, that's the quick summary of bipolar disorder. Next, we're going to talk about post-traumatic stress disorder, which we did a study on, and it was interesting how often people with PTSD, if they again with those checklists, misdiagnose themselves as bipolar, but it is really quite distinct, and the condition that I probably know more about than anything else. So I hope you learned something from that. Please come back. If you have some comments or thoughts about bipolar disorder, always add those. I love learning from you as much as I hope that you have learned from me. Take care.